delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 10 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 5 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval.
Good morning, everyone. I am Eileen Montero, Mu Sigma Phi Sorority Batch 1987, speaking in behalf of the Aging and Longevity Webinars team of the Mu Sigma Phi Sorority. We are streaming live from the video conference room of the UP Manila Information Management Service. Our time in Manila is now exactly 12 noon, and we have a total of around 350 people registered on the webinar all over the Philippines and from other countries as well. For today's webinar, we are privileged to have a distinguished alumna from the UP College of Medicine, class 1987, who graduated in the top 10 of her class as our speaker. She completed her straight internship, internal medicine residency, and fellowship in rheumatology in the Philippine General Hospital Medical Center. She also did her master's degree in clinical epidemiology at the UP College of Medicine. She has received the Paulo Campos Professorial Chair Award in 2016 and the Gawad Centenario Professorial Chair Award in 2018. Currently, she is an Associate Professor 7 of the College of Medicine at UP Manila and the Chief of the Section of Rheumatology, Department of Medicine of the Philippine General Hospital. Ladies and gentlemen, we are very proud and honored to welcome Dr. Evelyn Salido, Mu Sigma Phi Sorority Batch 87.
Thank you, Eileen. It's my privilege and pleasure to be the speaker for this afternoon. On the topic, arthritis in the elderly, is it inevitable? I hope the lecture will help you, your family, and your patients, and that these information will be helpful for your daily practice. These are my disclosures, and these are the things that I will be talking about this afternoon. Causes of arthritis, its epidemiology, treatment, prevention, and I will give a few pointers on how to keep our joints healthy while we age. Usually when our joints age or ache and we experience pain, automatically when we belong to the 40 years old and above, we think of it as an arthritis. But is it really arthritis? We know that the joint, as you see here in this illustration, is composed of what is inside the joint capsule. So we call that the intra-articular space, and the structures that support it outside, or the peri-articular structures. And when we feel pain in the joint, then any of these structures can be the cause of the problem. So it can be a muscle, which is spastic or torn. It can be a tendon, uh, or maybe a ligament. But it can also be problem inside the joint. So when do we call it an arthritis? It is an arthritis when the problem is inside the joint. Problem arising from the cartilage, from the subchondral bone, and the other structures inside. And we call it a periarticular problem or a soft tissue rheumatism when the problem is outside, from the muscle, from tendons, and the ligaments. So that is the first question that must be answered. Is it really arthritis? Sometimes we also feel pain in our legs, in our extremities, and it is neither an arthritis or a soft tissue rheumatism. Very often, we experience some tingling or numbness, and we think of it as pain, and it's probably coming from our nerves, which are dysfunctional. So we really have to make the decision whether the problem is truly inside or outside the joint. So when we decide that it truly is inside the joint, what do we do? No? Of course, we make our diagnosis and we plan out our treatment. What are the most common kinds of arthritis in the Philippines? You might be asking that. Okay. In adults, the three most common kinds of arthritis are, number one would be osteoarthritis, number two would be gouty arthritis, and number three would be rheumatoid arthritis. But there are many other causes and forms of arthritis. So arthritis is not just one disease that we think of. These are just a few causes, like microbes, no, trauma, a clotting defect, metabolic diseases, nerve dysfunction, immunologic dysfunction, and failure of joint protective mechanisms. So we can now link this to the different forms. And if you have microbes causing the arthritis, that would be an infectious arthritis. And as many number of microbes that there are, then we can have different causes of infectious arthritis. Trauma can give us traumatic arthritis. A clotting defect can cause recurrent swelling of the joint because of bleeding inside the joint. And an example of this would be in hemophilia. You can have a hemophiliac arthropathy. Metabolic diseases wherein you have deposition of crystals, no? For example, our monosodium urate crystals, calcium pyrophosphate crystals, or even basic calcium phosphate crystals, very common among our patients with chronic kidney disease. Now, these are crystals which can deposit in our joints and cause inflammation and arthritis. I have also seen patients with nerve dysfunction. For example, diabetes. No, their nerves have gone haywire, and some of them develop arthropathy. They don't feel their feet anymore, no, when they walk. So they put too much pressure, leading to an arthropathy. Now, the things I mentioned above, microbes, trauma, clotting defect, metabolic disease, and nerve dysfunctions are very definite types of arthritis. But sometimes we also have immunologic dysfunction, which up to now, although there is more research on this, there is still a lot that is not known. And examples of arthritis that are linked with immunologic dysfunction are rheumatoid arthritis and seronegative spondyloarthritis. When anybody has arthritis, and for example, let's talk about hemophilia, wherein you have recurrent bleeding inside the joint, or maybe gout, wherein you have recurrent inflammation because of the monosodium crystals in the joint. Uh, when the arthritis is recurrent, what happens? Eventually, you have scarring, you have the inflammation leading to a lot of enzymes being released, and this can eventually lead to damage of the joint. And when that happens, you have an osteoarthritis. So that is a secondary form of osteoarthritis. Although there is also a primary form, which is the more common one among individuals who are predisposed to develop the disease. Now, I mentioned earlier that the three most common arthritis among Filipinos are osteoarthritis, gout, and rheumatoid arthritis. Now, let me just give you a few details about these three different arthritis as we have seen them among our patients at the Philippine General Hospitals. So these are research done on osteoarthritis patients, around more than 800 of them with primary osteoarthritis. And we see that the mean age at diagnosis is around 63 years of age with onset at 59 years. Most of them are female. Men were shown to consult 10 months later, and the mean BMI is around 27, so that's obese. Women were overweight, but men were obese. And the most common comorbidities were hypertension in more than 50% of the patients we saw. The chief complaint was pain in more than 90%, and the knees were the most commonly affected joints. The x-rays showed moderate involvement, and when we looked at how they were treated, physical therapy was only used for less than 25%. And these were the most common drugs used. And less than 8% received intraarticular treatment or were referred for surgery. So we see here a very low use of physical therapy and intraarticular treatments and referral to surgery. And eventually, as a result of this study, a multidisciplinary osteoarthritis clinic was set up at the Philippine General Hospital, which is a virtual clinic wherein there is participation of rehabilitation medicine, rheumatology, orthopedic surgery, as well as the family medicine specialists. And we have seen an improved care of their patients. They receive a more holistic care. What about gout in Filipinos? Gout is a disease that is usually attributed to overindulgence with food and with drink, and usually found among males. But uh, what did we see in our patients? We saw that the age of onset was usually after 40 years of age. The more common illnesses that they had also was hypertension and diabetes. Many of the patients typically had monoarticular arthritis, meaning arthritis in only one joint, usually a joint of the lower extremity like the big toe or the other metatarsal joints or the ankle or even the knee. And you will see that when they consult the rheumatologist, a lot of them, as much or as many as 30% of them already have tophi, indicating prolonged illness. And around 20% already have had a urolithiasis. What is quite disturbing also that our data showed is that 50% of the patients already had renal insufficiency when they consulted at the clinic. The mean creatinine of 1.7 and a mean serum uric acid of 8 to 9%. So we think of gout as something which can be quite disabling, and the arthritis can really be very problematic, but we should also think that it can affect the kidneys greatly. And we see that renal insufficiency is a problem that we can avoid if these patients are properly managed. So we think of gout as something that is an intermittent arthritis, but if not properly managed, after 5 years or 10 years, it can become a chronic disease. And I have seen patients who have pain every day of their lives. And we don't want that for our patients. We also don't want our patients having to need hemodialysis or other forms of renal replacement therapy because their kidneys are not functioning well. What about rheumatoid arthritis in Filipinos? This is a review of more than 200 patients, again from the Philippine General Hospital. We see that the RA patients are younger. And what is also quite disturbing here is that it takes 5 years on the average before a correct diagnosis is reached. Very commonly, they also have other diseases like hypertension, tuberculosis, or diabetes mellitus. They commonly present as asymmetrical polyarthritis, meaning many joints are swollen and tender, and not everyone will have a rheumatoid factor positive test. No, only 60 to 70% have a rheumatoid factor test among our patients. So treatment usually given were prednisone, nonsteroidal anti-inflammatory drugs, and methotrexate. And only a few were able to access biologic treatments among these patients. So let's look at how prevalent arthritis really is among the adult population in the Philippines. Let me talk of two reports or two surveys which were done in conjunction with the National Nutrition and Health Survey. in 2003 and 2008. And these surveys were done on thousands of adults more than 20 years of age in thousands of households nationwide. And if you look at both the 2003 and the 2008 data, you will see at the bottom of this slide that the overall prevalence of arthritis is more than 6%, 6.5 in 2003 and 6.3 in 2008. And as you go down the age, you will see that even those who were in the younger age group already had self-reports of arthritis. So we see that arthritis is not solely a disease of old people, but what is very obvious here is that when you reach more than 40 years of age, then you really see an increasing trend of arthritis, both 2003 and 2008 reports. And that converts to 6 million adults with arthritis. Now, if you think 6 million, is that many? When we think of 100 million Filipinos, maybe not so many if you think that arthritis is really not so fatal or life-threatening. But if you think of 6 million adults who are not productive because of arthritis, then that is a big problem for the country. Why is there a higher prevalence of arthritis in the older age? Let's look at these three different diseases. Gout first. Okay. When we think of gout, we think of it as beginning with the first arthritic attack, but that's not true. There is an early phase of prolonged hyperuricemia, which is asymptomatic. And usually before the first attack of gouty arthritis, there already was 10 to 20 years of prolonged hyperuricemia, during which time the monosodium urate crystals have had the opportunity to deposit in our organs, not only in the joints. Among women, the onset is usually after menopause because our estrogen helps in our excretion, in our urinary excretion of uric acid. So when we lose that estrogen, there is the possibility of having gout among those who are predisposed. Therefore, you will really expect that there will be more older people who have gout. But in our study, we saw that gout in the young is a disease, and we have seen that in our patients in rheumatology, 15% have gout as early as 20 or before they're 30 years of age. So these are people who have had asymptomatic hyperuricemia since their teens. Okay, what about rheumatoid arthritis? Rheumatoid arthritis is a chronic inflammatory disease, and if the inflammation is uncontrolled, the damage resulting from uncontrolled disease can be cumulative. Therefore, you will see this becoming more of a problem when you get older. What about osteoarthritis? It is another disease wherein disease progression is low and there is increased vulnerability of the joint in aging. When we age, our articular cartilage is less able to synthesize the matrix that it needs to keep itself healthy. Also, the structures around the joint, the muscles, our sensory impulses, the ligaments, all of these become weaker and slower, and these can uh, be a problem in supporting our joint, thereby increasing vulnerability of the joint when we age. So let me give you my first tip. When you are you diagnosed with arthritis, then it's very important that early, aggressive, and continuous management of arthritis be done. So whether you are the patient or you are the doctor, this is very, very important to do. So let me stress early, aggressive, and continuous. We may be early and aggressive, but if we do not persist with treatment, then we may fail. Okay, so how do we manage arthritis? Very important is the correct diagnosis. I think this is challenging for many patients because arthritis, the kinds of arthritis, the way we diagnose this, sometimes what you see in the laboratory may be different from what the real problem is. Let me just give an example. Um, if you see a high uric acid, when you do the uric acid test, that does not automatically mean that the patient has gout. You have to look into the history of the patient. You have to look at how the arthritis presents before you're able to make the diagnosis whether this really is gout or not. No. Not everyone who has a radiographic finding of osteoarthritis will have symptomatic arthritis. I have seen symptomatic osteoarthritis. So I've in fact seen patients who have high uric acid, but when you look at their history, do their physical examination very closely, even when their x-ray is normal, the correct diagnosis is indeed osteoarthritis. So there must be very good correlation between your history and your physical examination, and sometimes the laboratory only contributes maybe 15 to 20%. So prognostication, you set your management goals, and very important is we reassess intermittently. Okay, so how do we manage gout? Again, you do thorough history and physical examination, and we have certain classification criteria. You look at the joints, are there tophi, are there crystals, how high is the serum uric acid, and important to remember here is that when we manage, we have different goals depending on what stage our patient is in now. So for example, our patient has acute gouty arthritis. Our goal of management is to control the inflammation and not to lower the uric acid at that point. But later on, when the inflammation has been controlled, then that is the right time to lower our serum uric acid, and not only to lower it, but we have to maintain it at a certain level, less than 6 milligrams per deciliter if there are no tophi, and if there are tophi, then we aim for a less than 5 milligrams per deciliter. So I think the operative word here is maintain. Now, we don't only aim for it, but we have to maintain it. And we have to reassess. Okay, so I'm showing this. It's very difficult to read, but always when we talk of gout, food consumption automatically is thought of. And we always think that um, when we limit certain food, then we can manage gout and prevent the gout attacks. Now, let me just spend 1 minute here. This is a study done early 2000. This is among Americans. So they looked at people who had gout, and they looked at their food consumption. So what they showed here is that more meat and seafood indeed increase the risk of gout, but dairy seem to lower the risk. And very important, moderate intake of purine-rich vegetables such as our beans, our nuts, did not increase the risk of gout. So we must remove this thinking or these concepts that we have to tell our patients not to eat beans and nuts if we want to prevent gout. Okay, what about rheumatoid arthritis? We were able, once we're able to diagnose it, then remission is our goal, and we constantly reassess our patients. Sometimes we get them very early, and like the picture at the left, you see the joints look just a little bit swollen. But if we're not able to manage properly, then you will see deformities coming in, and we don't want that. So we usually use a combination of many drugs, anti-inflammatory drugs, our conventional disease-modifying drugs, and for patients who are refractory to these conventional disease-modifying drugs, we have our biologic disease-modifying drugs like, for example, adalimumab, which is very useful or very helpful for patients who have very bad rheumatoid arthritis. So osteoarthritis, we need to control the pain. Sometimes there is some inflammation. We do get patients with osteoarthritis who have effusions, meaning there is inflammation there. Very important that we modify the risk factors, delay progression, and constantly assess our patient. Remember, osteoarthritis is one of the most common causes of chronic pain, which can affect our patients' ability to work. They cannot enjoy their lives and they become depressed. So we have to manage it by controlling the pain. We want to take care even of the emotional stability of our patient. We want them to be able to function very normally, as normal as possible. And if we can aim for remission or disease modification, then we should do so to improve their quality of life. So when we think of what treatment we give, we need to think that they must be safe for the elderly and even those who are younger but with comorbidities, should be convenient, available, and cost effective. So there are many, many different modalities for control of arthritis pain. And I would say that we usually use a combination of non-pharmacologic and pharmacologic agents and make sure that they are all effective and safe for our patients. So this is tip number 2. We have to control pain. Some of the patients will say, Doc, I don't want a pain reliever. I don't want a pain medicine. You know, uh, I have had so much pain in my life. I can take it. But I think what happens when we don't manage the pain, we tend to just sit there. We don't move, and we look here that when our muscle strength goes down, when our physical activity goes down, when we have certain wrong movements, this can all lead to joint injury, and this can increase our risk of osteoarthritis. So number 3, let us recognize and correct modifiable risk factors. Our children who have a little bit of genovalgus or genovarus or who are flat-footed, we must uh, give attention to this and do something about this. Protection from joint injuries, no? A joint injury that is not well taken care of can lead to osteoarthritis later on. So let me talk of obesity, which is one of the most common risk factors for osteoarthritis. Maybe we can end here and say that if we lose weight, when you decrease your weight by 5 kilos, you decrease your risk of symptomatic knee osteoarthritis by 50%, no? Something that we can all aim for, including myself. So let me just summarize, by saying that arthritis is very common among Filipinos, and there is effective treatment for arthritis. Let us not lose hope. It's not normal in aging. We can prevent arthritis in the elderly, and that prevention should begin during youth. Let us appropriately treat arthritis when it's diagnosed so that it doesn't become a problem when we get older. Let's correct modifiable risk factors. and do our best in always taking care of our patients wisely. Thank you very much for listening.
Thank you, Evelyn, for that very interesting and comprehensive talk. We now have around 467 people viewing us through Facebook, around 22 in the UP Manila live streaming, and around 80 on YouTube. So we have a few questions that have already been sent in through our through the comments section. And the first to send in the question was a question about the age. Even they just want to clarify that even as early in the early 20s, you can already have arthritis.
Yes, that's correct. There are some forms of arthritis that we can see even among younger individuals. In fact, there is arthritis among children. The youngest patient I have seen who has arthritis was a 3-year-old, and she had juvenile idiopathic arthritis. But among adults, I've mentioned gout as something that can happen even among people who are less than 30 years old. In fact, I remember seeing a patient who was 15 years old and already had tophi. And that patient was initially diagnosed to have rheumatic fever because he presented with arthritis. He had fever because of the arthritis. And for 2 years, he was being managed as rheumatic fever until I think he got frustrated, tried to look for another doctor. And when I saw him, it was quite easy because he already had tophi on his knuckles. So I did not have a hard time making the diagnosis. But you know, when you have tophi, then that means you have a bigger problem.
The disease has already progressed.
Yes, it's really a progressive disease already. And your targets are more tough. Like when you lower your uric acid, you really have to go down less than 5 milligrams per deciliter for you to be able to, remove those tophi. Remember, we can remove those tophi just with medications.
Okay, another question was in regards to treatment. When do you use hyaluronic acid injections for the knee? I mean, for the joint. Does it really work? Because I know there are hyaluronic acid supplements, but there's also hyaluronic acid injections.
Yes. Well, hyaluronic acid injection, that's a little bit controversial because there are reviews which say they work, there are reviews which say they don't. I think there are people who respond. The benefit mostly is pain relief. These drugs are good to inject among people who have tried other means, or you cannot do other means, like someone who has allergies to many drugs, or someone who has chronic kidney disease. So of course you cannot give a non-steroidal anti-inflammatory drug for pain.
So it's like a case to case.
Yes, very important is that case to case. And it would be best if there is no active inflammation when you do a hyaluronic acid injection.
There's another question with regards to the diet and gout. Does beer predispose you to or aggravate your gout?
For now, alcohol is still one of the more common triggers, or it is it increases your serum uric acid. Not only beer, even different kinds, the other kinds of alcohol. I have mentioned meat and seafood as other things that can increase your serum uric acid and can increase your risk of gout. So I think alcohol is number one that we want to limit among people with gout.
Okay. we both love to eat. I know that.
Oh
So,
yes.
so how much meat and how much seafood should we, I mean, limit ourselves?
Okay, that study by Dr. Choi looked at different levels of intake. So they saw that people, I have to review that. How much is the higher
Higher end.
intake? Okay, how much is higher? I don't want, many people are eating now. We don't want to spoil their appetite, but I would guess that if you eat it every day, and so I don't know, Eileen, how much is too
How much is
much.
too much?
Yeah.
So the keyword there or the magic word is moderation, I guess.
Yes, I would think that
Now,
would be.
there's a controversial question here because I know in other fields it's still not well researched. But in rheumatology, have you had peer-reviewed, double-blind studies with regards to stem cells? Stem cell for arthritis?
For rheumatoid arthritis, I think there are registered trials ongoing, if I'm not mistaken. A few studies on for our connective tissue diseases that also sometimes present with arthritis, like scleroderma, SLE. I know for a fact there are registered stem cell trials. I'm not very sure with osteoarthritis if there are.
So stem cells are still in the future, I guess. So before we can really say definitely that yes, stem cells will work for this.
Yes, right now we don't
We
really
don't
know.
have. So how about the food supplement glucosamine? I mean, does it will it work for prevention or will it help in the management of arthritis?
The clinical trials on glucosamine sulfate in particular, no, have looked into one particular preparation of glucosamine sulfate, which the pharmaceutical grade, which has been shown to help reduce pain among patients who have a moderate uh, level of pain and osteoarthritis. There is also a little data showing that it may help prevent uh, joint space narrowing, but whether it can prevent osteoarthritis is something that is not yet known. That is very, very different from all the other supplements that are not pharmaceutical grade, those that are that we can buy in our groceries and vitamin stores. That is another matter.
Okay.
And whether uh, chondroitin sulfate or MSM or combinations of these are really helpful is something that studies have not really shown.
Okay. So there's a question here. Can you differentiate osteoarthritis and rheumatoid arthritis if the Rh factor is negative?
Definitely. We remember the diagnosis usually is from the history and the physical examination. What difference will you see? Um, when they wake up, rheumatoid arthritis patients feel terrible. They feel terrible for an hour, 2 hours, maybe half day. Osteoarthritis patients will also feel terrible when they wake up, but when they start moving, they will say, "Oh, doc, after 5 minutes, when I start doing the things that I usually do in the morning, I'm okay." So that would be one question that's one question I usually ask. How are you when you get up in the morning? When they say I'm miserable for half the day, then and when I see that their joints are swollen, when you press especially on the wrist, no, very, very commonly affected are the wrists. And if the wrists are not affected, I don't think of rheumatoid arthritis. So wrists, the MCPs and the PIPs, those are the favorite joints affected by rheumatoid arthritis.
How about frozen shoulder? Is that osteoarthritis?
Okay, a painful shoulder can, well, frozen shoulder is different. So that's adhesive capsulitis, which is basically a soft tissue problem, but limiting the joint. But osteoarthritis is very different because in osteoarthritis you will see that it's actually the joint space which is narrowed, and they may present the same way, but they are different diseases. That's the short answer.
That's the short answer.
Yes.
But sometimes you see these young women who already have a little bit of joint deformity because of rheumatoid arthritis.
Yes.
Can that deformity? I mean, if you have a family history, what do they do so that it will prevent the deformities on the hands? Or in other words, can they prevent the rheumatoid arthritis from making itself prominent,
Expressed. Okay.
expressed? Yeah.
Well, even if you have the genes for rheumatoid arthritis, it does not always mean that you will have rheumatoid arthritis eventually. So if you have it in the family, can you prevent it? Yes, you can do something to help prevent it. I cannot promise that it will not happen, but smoking has already been linked, strongly linked with rheumatoid arthritis. So don't smoke. Um, Certain viruses, uh, even bacteria in our teeth, no? So, see your dentist, keep your mouth in tip-top shape, no? These are things that we can do to prevent rheumatoid arthritis because remember, there always is a contribution of our environment. So, but if you still develop rheumatoid arthritis later on, I said, have it managed early. I have a lot of patients who do not have deformities. So we can prevent the deformities. We can prevent the chronic pain if management is done early and properly.
So, okay, there's a lot of questions on gout, like how long should it be managed? Do people with gouty arthritis with high uric acid still need to take less than 6? I mean, uric acid is less than 6. Do they still need to take uric acid lowering drugs?
Okay. What is really causing gout? Many of Filipinos who have gout really have a problem in their urinary excretion of gout, and that is also to a big extent genetic. Therefore, since that problem is not permanently correctable, then intake of hypouricemic drugs should be lifetime. What if they already have achieved the target, no? What I mentioned as 6 milligram per deciliter, then we have to just keep them on the lowest dose of the medicine that can maintain the uric acid at that level.
So there you have your answer. You still need to take your uric acid lowering drugs. And how long do you treat gout? Same question was answered. You have to maintain it because
Yes, yes. These drugs, these hypouricemic drugs are safe. They are really intended for long-term use. We just need to make sure that we are conscious of the renal function, especially if you are giving allopurinol, because we cannot give high doses of allopurinol if the renal function is poor. We may have to think of giving febuxostat. Febuxostat is more, uh, its studies have shown that its use among people who have mild to moderate renal insufficiency is
it's
quite
quite
safe.
safe. Okay. Somebody here is asking is what is the best diagnostic procedure so that you can distinguish, you can diagnose rheumatoid arthritis. But I guess from what you said, it has to be really history and
History,
physical.
PE. The things that we look for will be the ESR, the CRP. Uh, it's really weird because some people have normal ESR but high CRP. So it's best if you take both, if it's possible. And if you can do quantitative tests for the CRP, if it's available in your place, then that would be perfect. We also do the rheumatoid factor test and the anti-CCP, or the cyclic citrullinated peptide test.
Okay. Another question here, this I think people who read a lot, how about platelet-rich plasma injections for arthritis?
Uh, yes, there is some data that show that it can be helpful for osteoarthritis. Again, I think as of now, the data is not very strong that I would want to use it on everyone, but it is an option on a case-to-case basis.
Okay, there's a question here. Does menopause worsen arthritis? And will biphosphonate Fusamax treat the arthritis related to menopause?
No, it will not. It will not treat. Bisphosphonates will increase bone density, but will not treat, like if you have osteoarthritis or rheumatoid arthritis directly.
Here we have a case. She's asking, she has a 16-year-old sister who is already experiencing symptoms of gout. What is the best advice that you can give to her?
Uh, you know, um, Gout in the young occurs in men. I have only, in 20 plus years of practice, I have only seen two women who are not menopause and have gout. So that gout in her sister uh,
Really needs to be verified.
evaluated fully. Yes.
Okay. So another question here is that with rheumatoid or with osteoarthritis, if you have, I mean, we all are aging. So when you reach into your menopause years and you still do not have the symptoms of osteoarthritis, what's the best advice that you can give our viewers to delay or at least even prevent the onset of osteoarthritis?
Number one, we have to keep our muscles strong. Okay, I know
Exercise.
that means exercise. And when I talk of exercise, that has to be individualized, because there are people who like going to the gym, there are people who do not like going to the gym. So you have to find what exercise best suits you. Number two, we have to pace ourselves. Um, and we have to listen to our body. I know these are things we need to adjust. We need to. I have patients who say, "Doctor, my knees are aching because I had to stand up. I cook the whole day, etc., etc." So I said, you can do it in stages. There's nobody timing you or watching over you doing all of these things, requiring you to do them. You just have to pace yourself. And let's not over diet. I know I said we must lose weight. I need to lose 10 kilos. I found out this morning. But we must make sure we have proper nutrition. When we lose weight too fast, our muscles suffer. So we must balance that effort to lose weight and keeping our muscles strong. We should, in our study, the knees were the most commonly affected by osteoarthritis. And I would advise that we keep our thighs, our glutes strong. because they bear the
Our weight.
our, we need our quads for us to get up from a chair. So I think we must be able to get up from a chair without assistance. And we can do that exercise. Or squats, no? But squats can help our glutes, keep them strong, but not if you have knee pain. So you must be able to know how to squat without putting so much weight on your knees. So that takes a little bit of practice.
So diet, exercise, and
Pacing,
pacing.
avoiding injuries.
Avoid injury.
Avoid injuries. I tell my patients, if you have knee pains and your toilet bowl is so low or your sofa is so low, change it, throw it away. No, you shouldn't put so much effort when you get up.
How about footwear? There are some.
Oh yes, very important, no? So if you're flat-footed, uh, when we age, the more our feet become flat. And that puts stress on our feet and on our knees. So we must also look at the feet when there are pains in the knees. Yes,
So
and
no high
correct.
heels.
Oh, definitely. Throw your high heels
away.
well, if you're flat-footed, then you need a good arch support.
control. Yes, arch support. How about what do you call this? Are there special orthotic shoes that you can that are recommended for people with osteoarthritis, or it depends on the if they have flat foot? Or
Yes.
it depends
It will depend on the evaluation on the problem.
of the
So
problem.
that's
So
why we work hand in hand with occupational therapy, physical therapy. We need their help in thinking of these orthotics, what's appropriate for our patients.
okay, thank you. Thank you for our viewers for all the questions that you sent in, and thank you very much, Evelyn, for having come here and with a lively discussion. So, in summary, what Dr. Salido is saying is that arthritis is not inevitable with aging. If it does happen, it can be treated, and the treatment is done best early. So if you have your pains, you better go to your friendly neighborhood rheumatologist and have it diagnosed early so it can be treated, because pain is not our friend. Okay, so your pain is not our friend. Okay, so with that, we'd like to thank Dr. Evelyn Salido for taking time out of her busy schedule. I know she's very, very busy, and sharing with us her expertise. And please stay tuned for some reminders.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Phi Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST-ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. We would also like to thank our sponsor, Abbott. To receive your certificates of attendance, kindly answer the evaluation form by visiting the link on your screen within 2 days. The certificates will be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at YouTube at Aging Webinars channel. Please join us again on our upcoming webinar as seen on your screen. We are also announcing the launch of the OB Pearls book. Get your copies now. We would also like to invite you to attend the UP Med webinars every Wednesdays. Thank you and have a great day. The Aging and Longevity Medical Webinars team